So we're running a little ahead of time, but just want to point out, so a couple of things coming up next. We're going to do the Jeff Riley Scholarship. So this is a prize that we have set out for the students who write the best presentation and give the best presentation. We have several applications every year, which are from students in their second year of studies. And so first place, we'll get a check for $1,000. Second place, we'll get a check for $750. Third, a check for $500. And fourth place, a check for $250. So everyone's a winner, that's like we say. What we're going to also do is give them a certificate. And what we hope to do with this, and we're going to try and keep this going year after year after year, is that we will give new people into perfusion the chance to stand up in front of people and get the confidence to talk. It's not something that comes naturally to everybody. It's not something that people enjoy necessarily. But by hopefully giving them this opportunity to try it out, we will then develop people who can then come back year after year and tell us about the interesting research that they are doing. And as part of that also, and it's something I will mention at the end as we wrap up, we're also, as part of the Sanibel Symposium, opening up free registration to this conference for any students in their first or second year of training from any country in the world. So. And if they want to do this and they have this, they can come in. So this year is the first time we've actually had an international student as well on the podium for this prize. So this is what I believe, from what I know of Jeff Riley, I sadly never met him and had this conversation, but I know from the work he's done on the papers I've read, is I believe this is what he would have wanted us to do. So I'm very happy to kind of have that and sort of really put what I think he would want into this. So without further ado, I'm going to hand over to John, who's going to moderate this session. So thanks so much.
Thanks everybody for joining us to the student speaker session. The Jeff Riley Scholarship is awarded to perfusion students who compose and present an outstanding presentation here at the Sanibel Symposium. Our first speaker is Jacob Crisafulli. He is a perfusion student at Quinnipiac University, and he previously obtained a master's degree in biomedical engineering.
Hi, good afternoon, everyone. Thanks for that introduction, John. So as you mentioned, my name is Jacob Crisafulli. I'm a cardiovascular perfusion student at Quinnipiac University, and today I'm going to be presenting my thesis research into induced fibrillatory arrest. So a little bit of background, everyone knows myocardial protection is the foundation of safe cardiac surgery, and I think everyone uses some form of the 150 different types of cardioplegia that's been out there. Well, prior to cardioplegia in 1952, Dr. Senning described utilizing elective ventricular fibrillation to facilitate different intracardiac operations. And this remained the primary method until cardioplegia achieved widespread adoption. And fibrillation preserves the myocardium while also providing continuous coronary perfusion, and just can be used in a lot of patients where you have difficulty placing a cross clamp. You can't place a cross clamp because of risk of embolic stroke, heavily calcified aorta. So that's kind of what I'm going to be going into. So any kind of talk about fibrillation, you have to consider myocardial oxygen consumption. So we all know at normothermia, 37 degrees, your fibrillating heart, that's bad. You have a high left ventricular oxygen consumption, you have a high wall motion, and Buckbird has described this, and you can see there's different types of hearts on cardiopulmonary bypass, whether it's beating heart, fibrillating heart, and a fully arrested heart. But when it's combined with hypothermia, the fibrillating heart has reduced oxygen consumption than that of the decompressed heart. So it is an option, but it has to be combined with some type of mild to moderate hypothermia. So going into cardioplegia, any type of solution you use is going to have some type of damage due to the subsequent ischemia reperfusion injury. So the resulting ischemia sets an emotion of biochemical and structural changes that can become irreversible if that anoxia is prolonged. There's a lot of hypotheses about the ischemia reperfusion injury, such as calcium overload, intracellular acidosis. generation of reactive oxygen species, which all can lead to reversible and irreversible myocardial dysfunction. So here's an example of a patient where fibrillatory arrest can be useful. So here's a CT that shows diffuse and heavily calcification of the ascending aorta. And this patient, it was also a redo operation because they have a mitral valve replacement and a bioprosthetic mitral valve and also a tricuspid ring, which you can see with the arrows. So what are we going to do with these patients? You can't place a cross clamp because you're going to have risk of embolic stroke. Obviously, you can't cannulate up there, so you're going to have to use a different strategy for that. And in this patient specifically, they use hyperthermic fibrillatory arrest via minimally invasive right thoracotomy, and they're able to do a mitral valve replacement without complication. So some of the applications that I just mentioned, minimally invasive and robotic mitral valve surgery, re-ops, you just avoid that extensive dissection around the aorta, especially in patients that have previous coronary anastomoses. It's also been described in emergent, elective, and just CABG's procedures. And there's also a growing population of the adult congenital world. And I think everyone in the pediatric community, they're probably more aware of fibrillatory arrest, and it's used more often in their day-to-day practices. And that's kind of where I got the idea of this. During my observations, I was luckily enough to see fibrillatory arrest, and the surgeon asked for the fibrillator, and you're like, wait, what did you say? He's the fibrillator? I mean, at me as a student, I'm like, okay, well, we'll get the defibrillator out. And he says, no, the fibrillator. So that was really interesting just to see. And these patients are surviving longer. There's useful for RV to PA conduit replacements. I've seen it done. Luckily enough, my last rotation has an adult congenital program, and they've done a lot of it research in Epstein anomaly. So, and also intracardiac EP mapping. You can just fibrillate, open up the heart, and then see where your sutures need to go. So some of the advantages of fibrillatory arrest: surgeon can open up all the chambers of the heart without risk of introducing air and subsequent ejection. Your coronary blood flow is maintained. Also, you don't have that period of ischemia, and provides a solution for patients with a fragile or porcelain aorta. And there's also a technique known as intermittent cross-clamp fibrillation that is used for more routine patients, which also might have the phenomenon of ischemic preconditioning. So disadvantages: it's not a solution for patients with severe AI. It's also not a solution for patients with hypertrophic ventricles due to inadequate coronary perfusion. And it's also, your heart's still moving around, so that it's more technically difficult, but in an experienced surgeon, they can do it without problem. So here's an example of a fibrillator device that you might see in the operating room. You can either use this, you can do rapid ramp pacing with the pulmonary artery catheter, or you can just start cooling once you get on bypass, and you'll spontaneous fibrillate around 32 degrees. Most of the time you go to 28 to 32 degrees for hypothermia. And we all know the rate of fibrillation along with the strength of myocardial contraction decreases the more colder you go. And when you get to about 28 degrees, your O2 demand decreases by about 40%. And once the operation is complete, sometimes the heart will spontaneously just go back to normal sinus, or you can defibrillate. So looking into the study that I performed, just looking at, does induced fibrillation provide equivalent myocardial protection compared to cardioplegia? And some of the materials, so a multi-center systematic review and meta-analysis was performed. Study items were collected manually based on fusion parameters, study characteristics. Everything was documented in Microsoft Excel, and I used the programming tool R for statistical analysis. And these are some of the databases that I used. Some of the endpoints I was looking for was ICU and hospital length of stay, cardiopulmonary bypass time, cross-clamp time for when they use the intermittent cross-clamp technique, need for an intra-aortic balloon pump, long-term inotropic support, post-op atrial fibrillation, and 30-day mortality. So the inclusion criteria for my study, I looked specifically at the adult population because induced fibrillatory arrest is kind of more known in the pediatric world. And so I was like, why isn't it used in adults that often? So any kind of cardiac surgery that used fibrillatory or cardioplegic arrest, limited the published date because it is an older technique. So I limited it to 1980 to 2023. And I did two types of analysis. So the primary analysis was just isolated CABG procedures, and the secondary analysis was more on the minimally invasive and standard sternotomy mitral valve surgeries. So looking into the primary analysis, this Prisma flow chart just kind of goes over how the studies were picked and why they're excluded, whether it was an animal study or individual case report. And in the primary analysis, looking at CABGs, there was 24 studies that I included. So this chart just shows the author, the year of the study design. Most of them were retrospective or randomized controls trials, whether it was multi-center or single center, the country it was performed in, the total cohort, mean age, gender, and the technique used. So for the fibrillatory arrest group, there was over 18,000 patients that I included in the study. And here is the cardioplegia group, where 7,212 patients in total were used to collect the data from, and also had 12 independent studies. So I highlighted in red the most statistically significant findings. So you can see cardiac bypass time was actually significantly decreased in the fibrillatory arrest group by a little more than 20 minutes. Cross-clamp time was also decreased when intermittent fibrillatory arrest was used, and hospital length of stay was decreased, as well as 30-day mortality. And I created this forest plot. There was 5 studies that looked at both cardioplegia and fibrillatory arrest, and the mean difference on cardiopulmonary bypass was also favored fibrillatory arrest. Looking at long-term survival using this curve, you can see in green is the cross-clamp fibrillatory arrest group, and the blue is cardioplegia. So even stretched out to 15, 20 years, these patients have a similar outcomes. Cardioplegia is always going to be the gold standard, and your everyday cases is going to be with cardioplegia, but when you need to use fibrillatory arrest, you can have pretty good confidence that things are going to go pretty well. Similar thing for the secondary analysis with mitral valve surgery. Here's a Prisma flow chart. There's 18 studies, and looking into those, there was, 2,500 patients were included in this group for fibrillatory arrest, and there was 7,000 patients from 5 studies included where cold cardioplegic arrest was used. And looking into the results of this, so the only thing that was really statistically significant was the neurologic complication. Fibrillatory arrest has been has this issue that you're going to have high risk of stroke, but I found in my data that actually wasn't the case, and everything else had similar times. So kind of the results of this meta-analysis shows that fibrillatory arrest is a safe and effective method, and you can achieve similar clinical outcomes as seen with cardioplegia. Multiple studies have also looked into the release of biochemical markers and myocardial ischemia markers. There wasn't enough data to include it in my thesis, but it has been studied. And an attractive feature of fibrillatory arrest is all you need to do is buy that fibrillator box. It's reusable, and then you just have to buy the temporary pacing electrodes that are disposables. So that could be a solution when supply chain issues arise and you can't get cardioplegia because for whatever reason. So some perfusion considerations, it's, as I mentioned, typically combined with mild to moderate hyperthermia, 28 to 32 degrees. You want to have some higher perfusion pressures. So your maps, you want to be closer to 80 to 100 just for adequate coronary blood flow. LV venting is essential to prevent distension and also decrease your myocardial oxygen consumption. And for minimally invasive mitral valve surgeries, use CO2 insufflation to displace intracardiac air. You can gently retract the aortic valve to allow the LV to fill, and then that's how you can test your mitral valve repair or replacement. And then de-air using a transmitral vent placed through the left atriotomy closure. And some future directions, I would like to see some more echocardiographic studies done, as well as angiographic studies to look at kind of long-term quality of the anastomosis. And also, as I mentioned, there are some studies that have looked at biomarkers and enzymatic assays to gain an understanding of the level of cardiac injury and insult, but I think more studies should be done there. And then one study has shown that ischemic preconditioning does confirm some protection to the myocardium just by giving it a little bit time of ischemia, and then it has this kind of built up for prolonged periods of ischemia where it does a little bit better. And you can see one study did show that 72 hours post op, that ischemic preconditioning did decrease the amount of cardiac troponin T release. And yeah, that's it. Thank you.
Thank you. Very nice presentation. It's open for questions, I suppose. Yeah. Okay. I just had two remarks. A really good presentation and well executed work. Thank you. You didn't mention intra-aortic balloon pump in the differences.
There was a chart. So if we look at like the results, you can see the secondary analysis, intra-aortic balloon pump, it was statistically significant of a decrease. You can see it's right under cardiac valve bypass time. And then also in the CABG group, there was also a less need for intra-aortic balloon pump as well. That was statistically significant, but I just wanted to hit on the key ones that I thought were interesting.
And could I see the curve of the survival or mortality again?
So this is a Kaplan-Meier curve, just showing like the cumulative survival.
Okay.
So you stretch it out more.
I just wanted to confirm something for myself. Thank you.
Mm-hmm.
I have one more question for you, Jacob. Yeah. Very nice presentation. I appreciate your work. Yeah, I have a question on you. I mentioned several perfusion strategies and stuff. Could you go over again about if there's some complex aortic calcifications, what would different strategies you would think about or talk with your physician for cannulation on those type of patients?
So if I go back to this kind of CT scan, in this patient specifically, obviously you can't clamp the ascending aorta. You can't put any type of a cannula in there. What they did in this patient specifically was axillary cannulation, and then for venous, just standard RA IVC when they opened up the chest. And then I've also, in my rotations, have done fibrillatory arrest for porcelain aortas as well. And the patient didn't have extensive pulmonary artery disease, so they did just fem-fem cannulation, and everything seemed to work pretty well.
Okay, very good. Thank you.
Thank you.